He left her. Can I call him?
बराबर है
कनेक्शन इश्यू है कोई?
नहीं बराबर है परफेक्ट है भाई
Okay.
एयरप्लेन मोड में डाल लेता हूँ मैं
Okay. Hi, Sai, you can.
Yes, sir.
Okay, start.
Good evening, everyone. Welcome to Vijaya Diagnostics Education Webinar Series. I'm Dr. Saikrishna, Consultant Nuclear Medicine Physician from VDC Tirupati. So today we are here to have a discussion from the topic being role of nuclear medicine imaging in urinary tract infections. So here we have today two eminent faculties, our chief guest, Dr. Mohammed Shoeb Ahmed Khan, Director of Nephrology and Transplant Services, SAP Kidney Center, Hyderabad. I welcome you, sir. Sir did his MBBS from Southern Institute of Medical Sciences, Hyderabad, and MD Internal Medicine from Deccan College of Medical Sciences, and later worked as an assistant professor there itself. Followed by DNB Nephrology in Astral Medicity. Sir has a certification in European Society and Board of Nephrology, fellow in College of General Practitioners. Sir has a very huge list of presentations and publications in national and international levels. So thanks for accepting this invitation, sir.
Yeah.
I welcome you, sir. And today's expert speaker is Dr. Mohammed Mansoor Mohiuddin, sir. Sir did his MBBS from Deccan College of Medical Sciences, followed by DNB Nuclear Medicine from Apollo, Hyderabad. Currently, sir is working as a nuclear medicine consultant in VDC Himayat Nagar branch. Sir has many presentations and publications at national and international levels. To mention a few, Sir got Arcot Gajraj Best Paper Award and as well as a Travel Award for IIEA Vienna, Austria. I welcome you, sir.
Thank you.
To begin with, we'll start with Dr. Ahmed Khan, sir, and to give his clinical perspectives in urinary tract infections, where does imaging stands, etc. Over to you, sir.
Over to me.
Sir, sir.
Yes, Dr.
Yeah,
Shoeb,
yeah.
yes.
Imaging is, I think it's very important in diagnosing any form of urinary tract infection, because whenever we talk about urinary tract, it's important to see the urinary tract and the way it is built. The structure is the most important thing, and structure can be seen by two ways. One is by going inside, that is invasive, and other thing is by seeing from outside, that is non-invasive. Non-invasive is always preferred, and for any UTI, be it children or be it adult, I think an ultrasound abdomen with a post-void residue is the most important and a basic test which should be done. Followed by, if it's a pediatric age group, like less than 14 years, somebody having a UTI, it's very important you rule out a reflux. So that's where imaging is important by getting a vesicuratoric reflux imaging done. And micturating, that's also invasive because we put in a urinary catheter that may be sometimes difficult. And second thing is in imaging, one is ultrasound we have spoken about, second is radiation based x-rays or probably a CT scan, and lastly is nuclear imaging, which is quite safe and which could be done regularly, and sometimes sedation is required, but I think it's a good modality to look at how much each kidney is working, whether a kidney has got a scar in that or not, whether there is a significant obstruction which needs to be addressed surgically, and follow-up of a reflux by getting a DRCG done is also very useful, and it's quite safe. Unlike exposing a pediatric small boy or girl to multiple x-rays and taking films of them while urinating, I think DRCG holds a much better investigation modality. So anybody who gets a UTI once, if the age is in the pediatric age group, needs to be evaluated for reflux, and that needs to be followed up with DRCG. And anybody who is having a hydronephrosis needs to be evaluated by DTPS scan. And anybody who gets UTI at least twice or thrice needs to be checked with a scar cellular by getting a DMSS scan. So I think imaging is very crucial. It's one of the fundamentals in the process of management of a person with UTI. Yeah. That's what I feel.
Thanks for the insight, sir. And now we'll have a presentation from Dr. Mansoor, sir. Sir, over to you, sir.
Hi, good evening, everyone, and thank you for the kind introduction. And thank you, Dr. Shoeb, for the brief uh, explanation you have done and how you use imaging in your practice. And now I'm going to speak on specifically on the role of nuclear medicine imaging in evaluation of UTI. I will skip the ultrasound and the uh, micturating urethrogram and uh, the radiological investigations that you said which give high radiation. Uh, During the course of the presentation, I will show you what are the differences in between them and where we use and what to use, and some algorithms also we will touch upon. UTI is frequent in children with a prevalence of 5%. It affects girls twice as often as boys. 80% of first infections occur during the first 2 years of life. Diagnosis relies on urine cultures. The most important thing is to differentiate between a lower UTI from an upper UTI, where there is a specific treatment for the upper UTI. And most importantly, we need to differentiate this in order to prevent the complications that can happen during the course of time, the complications which can be there cause comorbidities during the life of the patient. And the only symptom being fever, so it becomes difficult to differentiate this clinically, and delay in the diagnosis causes renal damage. So the goal of imaging would be to identify the patients at risk, identify patients with congenital anomalies, with reflux, or the patient is having a functional bladder bowel dysfunction, and to prevent further infections and to prevent progressive renal damage. And as already highlighted, we use ultrasound as the first modality, then micturating cystourethrogram, and then the role of DMSA and the radionuclide cystogram comes. So we do DMSA scans. DMSA stands for dimercaprosarcinic acid, which is analog of dimercaprol, which is a chelating agent. And the other tracer used is glucoheptonate. We commonly use technetium-3 DMSA, and it is bound to the proximal convoluted tubules. The mode of uptake is peritubular extraction, tubular reabsorption, and it also binds to the megalin-kubulin receptors in the kidney, renal cortex, and this is similar to the binding of the Dotanog that we use in PET scans. So that was about the physiology, and this is how the scan looks like. We give an intravenous injection of the tracer followed by imaging after 3 hours. You can see that the tracer, there is a good uptake in the renal cortex, and this is how the scan looks like. In case of normal kidneys, you can see a normal smooth contour, and the shape of the kidney is also proper and uniform, and equal uptake is seen in both kidneys. They're more or less of same size, and you can see a very good back clearance of the tracer from the background. So this is a normal scan, and we acquire posterior image and oblique images. These are three most important views. And then we can do some calculations drawing a region of interest around both kidneys. You can get the split or differential function, which is the function of one kidney relative to the function of the other kidney, and then you can do a geometric mean also by using anterior and posterior images simultaneously. This is how a scan of a pyelonephritis looks like. You can see on ultrasound that there is cortical thinning and scarring of the cortex, and this is how it looks like on the DMSA scan. Whereas this is a case of severe pyelonephritis. You can see that the uptake in the right kidney is very, very low compared to the left kidney. You are not able to delineate the margins, and you can make out that the contour also is irregular, and there are peripheral photopenic defects which correspond to the renal scarring. So the sensitivity is 90%, specificity is 80 to 90%, and very high negative predictive value. If you're seeing normal kidneys, then completely rules out urinary tract infection in children. And then this is a diuretic, a direct radionuclide cystogram, where we give a suprapubic injection into the bladder. We use technetium DTP, a very small quantity of radiation we use here, and in a full bladder we inject it via direct injection, suprapubic injection, and we ask the patient to void. And during the voiding phase, we can see the reflux into the ureter here. Since this is a posterior image, this is reflux into the right ureter. And as the patient is voiding, we can see the reflux going all the way up to the pelvic calyceal system. So this is a high-grade reflux in the right kidney. This imaging gives very low radiation to the to the bladder, and especially in a female patient to the ovaries we get very less radiation. And it is this, of course the injection will be painful, but it will be only for a very short duration of time. There is no risk of ascending infection, uh, as we are not using any catheter. This is this has higher sensitivity, less radiation exposure. It is a simple procedure, but the main drawback is you're not seeing any anatomical details. So you will not know whether there is a posterior urethral valve, there is a uretrocele, or there is a duplex moiety. It's very difficult to see all these things, and for that, to know how the anatomy is, you would have to do a MCUG once at least, and the DRCG scan would be ideal in following up the patient. This is how MCUG looks like, and here you can see a good deal of anatomy. You'll see if, and this is how the grading of reflux is. If reflux into the lower ureter is grade 1, all the way up to the pelvic calyceal system is grade 2, and if there is blunting of fornices, it's called grade 3. This is significant dilatation, and if it is highly dilated and tortuous with intrarenal reflux, then it is grade 5. And you can see that there is duplication there, and then the very thin curvilinear opacity in the membranous urethra with posterior urethral valve, or if there is a filling defect in the bladder, this is a uretrocele. And let us look at some cases. This is a 6-year-old girl with high-grade reflux on the right side, and no evidence of pyelonephritic foci. This is a normal scan. So patient with a reflux was evaluated to see if there is any pyelonephritis. And this is a 7 years girl with high-grade reflux on the right side. And here you can see a small defect in the right kidney, in the upper pole of right kidney. So this was positive for pyelonephritis. And this is corresponding to the ultrasound also. And recurrent UTI in bilateral reflux, you can see that there is central photopenia in both kidneys, suggesting that there's hydronephrosis. And you can see peripheral defects. If the defect is peripheral, we call it pyelonephritic focus. If it is central, it's more likely due to hydronephrosis. And then you can see that the renal contour is affected in both sides. There's an interpolar cortical defect here, a lower pole. So this is the right kidney, and it is relatively enlarged compared to the left kidney. This is a case of bilateral pyelonephritis. And again, this is a case of hydronephrotic right kidney. You're seeing that the right kidney is enlarged. This is the anterior. This is the left kidney, and this is the posterior image. So the left kidney is enlarged, and you can see central photopenia, which is suggestive of hydronephrosis. And but there are no peripheral photopenic defects. So this is hydronephrotic kidney with no evidence of pyelonephritic foci. And again, patient with high-grade reflux on the left side, you can see that there is hydronephrosis with defect in the upper pole. So there is pyelonephritis along with hydronephrosis, and we are not able to see the right kidney. So the right kidney is absent. And this patient has chronic pyelonephritis, and the contour is affected on both sides, and you can see that the background activity is also elevated. So this is chronic bilateral pyelonephritis with renal insufficiency. And as I already said, that DMSA is a gold standard, and it has a very high negative predictive value. And then this is a example of a DMSA spec, and it improves the accuracy of detecting uh, cortical scars, and it is more useful in adults because if you do a SPECT CT, you can differentiate it from a cortical cyst, a cortical scar from a cortical cyst, but that would give added radiation. The SPECT doesn't give, but the SPECT CT gives added radiation. We don't usually do the EMS SPECT. And so this is an example of an adult patient where you can see that there is defect in the upper pole of right kidney, which is corresponding to the DMSA scan. And you can see that if there are other lesions in the kidney, you can differentiate with the help of CT scan. And some salient points: DMSA scan is used for assessment of cortical function, and you can diagnose pyelonephritic foci with higher accuracy. You can assess the renal scarring and severity. Uh, there is high inter-observer agreement, and you can use it for follow-up as it has very less radiation and simple procedure. And DRCG effective dose is very, very less. It gives 10 times less radiation than a radiograph of the chest. And the effective dose of MCUG ranges from 0.03 to 0.4 millisieverts, and this is about 100 times less if you compare. And DRCG has a higher sensitivity, and a simple procedure. But the important point is that the child needs to be toilet trained. And this is an example that I would like to show that it was negative for reflux, DRCG scan that I had done, but the MCUG had shown reflux. So the problem with this scan is that the bladder was not full. So we need a full bladder, which is very important. And so if bladder is not full, you might miss the reflux. And these are the risk factors for UTI in children. Include poor perineal hygiene and prolonged use of diapers, congenital anomalies, bladder ball functional dysfunction, and almost 50% of children with recurrent UTI and 10% children presenting with a single UTI have an associated urological abnormality. That is why they get evaluated such extensively. And in case they find any abnormality, then they would be placed on a prophylactic antibiotic course. And fungal UTI is more common in immunocompromised patients in ICU settings and prolonged antibiotic usage and presence of a long indwelling catheter. So this is the algorithm used by Indian pediatrics, and this is how we should approach any patient. I won't go into the details. I just wanted to show the algorithm which is available, and we can follow this. And UTI in adults, imaging where conventional treatment has failed, there comes the role of nuclear medicine. And it's more common in immunocompromised patients with diabetes and with renal calculi. When pyonephrosis is suspected, there is a chance that there might be it might be due to obstruction. So these are the investigations that we do. And here the role of DMSA is very limited, and we use DTPA scan to assess the renal drainage and renal function, to get a split renal function, and to assess the GFR. That also helps us in follow-up. This is a 58 years lady with left pyonephrosis, and you can see that the DMSA scan, there is increased background activity, and function of the left kidney is severely affected compared to the right kidney. And the GFR is also poor, and split function is also poor in the left kidney. Another example of a patient with renal calculi who had been operated, and we do a DTPA scan to assess the function. This patient also has some renal insufficiency, and we can see that both sides the kidney is affected, but the right side is affected more. And in adults with fever of unknown origin, we can sometimes detect UTI where there is an increased uptake in the renal cortex, even on delayed imaging after diuretic intervention. So that could be a focal lobar nephronia, and in PO we sometimes have this finding. So to summarize, imaging plays an important role as it is already highlighted, and then we have seen in the scans. And can UTI in children and in adults is a little bit different, and we use different imaging modalities for both. And these are the different imaging modalities that we've seen, and we use uh, these scans for children, and ultrasound and CT scan for and renogram in adults. And FDG PET-CT has a role in pyrexia of unknown origin. So we have come to the end of the talk. Thank you very much.
Yeah,
That was
very
a very
nice
nice
presentation.
presentation. Please.
Acha, yeah, it was a very nice presentation, a detailed thing, and I got to know a lot of new things. Most importantly, that 100 times reduced radiation in DRCG is a very useful thing. So probably somebody who gets a UTI, the standard of care is to do an MCUG, look for reflux, and follow up is annually. That's the guidelines. Annual MCUG is till the reflux has burnt out or till the age of at least 12 years. Then if symptomatic UTI is there. But I think DRCG is a lifesaver. It can reduce the risk of cancers in the future. So I think
You can
DRCG
assess
should be
the anatomy
more.
in the initial MCUG scan, and after
More.
ruling out any anatomical uh,
Correct, correct, correct. So first
after
MCUG rules out almost all the anatomical issues, and then follow up with the DRCG is very useful. I think this should be aggressively promoted among many clinicians because I don't think it's that much popular. But the difficulty is again that full bladder child, a
yes, not to be
four-year-old,
careful. Yeah,
hmm, he can't tell a 3 years old child to tell मेरा bladder full है बोले तो it's
and they cannot hold also after it
they
is full.
cannot hold, they cannot hold also. So probably with little bit more the senior guys 6 5 years it is more practical of use, and the role in fever of unknown origin is also very crucial. It's very nice.
Another indication is that you evaluate the siblings
Yeah.
in so you can use a DRCG scan because it is
Mhm.
uh, lower
Correct.
gives lower radiation, and it's
Lower
simpler,
reduction. Yes,
and they
it's
don't have
sensitive.
symptoms in an asymptomatic sibling, so role of
Correct.
DRCG can be helpful.
Yes, it's autosomal recessive. Yes. I one just one. It's maybe a stupid question, but just for CT scan, MRI, everywhere, wherever we see the images, the films, right kidney is on the left side, but only this nuclear imaging, it comes on the right side only. Why is that
Yeah,
so? I don't know. It is the posterior view. That's okay.
yes. The
That
standard
is
in
because
imaging is the right side is always towards uh, left of the
Yeah,
image.
right. In the film, is
But
the left. Yeah, that's how it is
when you
seen.
do an anterior imaging, you get an image like that. But if
Like
you're
that,
doing a
just like our
posterior imaging, it becomes opposite.
correct, correct. Just like our camera right now. Well, the right hand
Uh,
लगाए तो वैसा दिखेगा. Right. That's one thing. That's all.
sir,
Otherwise,
for just for the discussion's sake, sir, I mean,
yeah.
when you are giving the suprapubic injection directly in a full bladder, I mean, does it clinically, I'm asking the nephrologist, sir, does it clinically
Yeah.
helps us to differentiate low pressure and high pressure reflex? And does it, matters for the patient if you know about the low pressure and high pressure reflex?
Yeah, it definitely matters because we can't differentiate low and high because PUV we can't see in that. The only the degree of reflux we can see. So high pressure, low pressure thing is something which is seen on urodynamics. Uh, can't be seen on MCUG also. So definitely it matters. If it's a high volume, high pressure bladder, then it will be a posterior valve associated or secondary to any bladder outlet obstruction. So I don't think DRCG is relevant enough there to differentiate those things as elaborated in the presentation itself. So it's like that, yeah.
if you see reflux even before the patient starts voiding, then we call it a
Mm.
low pressure reflux. If we
Then
see
low
reflux
pressure. Okay.
during voiding because it's contracting, then it becomes high
Okay.
pressure.
Oh, so that's one thing is there. Fine.
It's
That's good.
just a rough way of saying it.
Yeah, rough learn. Much better. Maybe a presentation. Has it. That's good. One more thing,
If there are,
DNS scan, initially it was told that, we need to do it after 3 months of UTI after antibiotic course is over. Presently, they have brought it down to 1 month or even during the UTI also many people tell that we can go ahead and do it.
Yeah.
Uh, so,
So initially during UTI, there is edema.
hmm,
So we allow it to subside, and then that was the previous understanding. And
correct, correct.
then, as you said, you're doing it earlier. But if a requisition is asked for, we don't send the patient back. In that, you have not completed your
But,
3 months.
nowadays, I think people are like, the more recommendations telling that, we can do it earlier also. Already patient is on an antibiotic cover. So what happens if you do it? If the kidney is involved, if the uptake is less, that will become a scar probably later on. That's
Yeah.
what it means.
So you detect it with an ultrasound,
Yeah. Okay.
and then you follow it up. It's like that.
Yes.
And
Yes.
so residual scarring of the kidney,
Yes.
to assess that, then this becomes really
Yes.
helpful.
Yes. Yes, sir. Very nice. A very well elaborated presentation, sir. Acha, very nice.
So if there are
Yes,
no
thank
more questions and no further discussion, we will wind up this session, sir.
Mm.
Thank you very much for the active participation, sir.
Mm.
I thank the Vijaya Diagnostic
Such a
management and team. So please,
such a
please
detailed
proceed.
presentation. Such a detailed presentation was made. It was very educative. I wished all nephrology PGs would have been invited to this talk. It would have been very useful for that exam because such a exceptional points were given very distinctly, nicely, 90%
This will be
sensitivity.
available on YouTube, and
This
you
is on
can
YouTube.
ask.
Link मेरे को भेज दिया था. I have sent it to our nephrology groups
Sure, sure.
because it's a very well made out. I mean, exam के answers है पूरा. It's very well made out. Yeah, nice presentation.
Thank you, Dr. Sai.
Okay.
Sir, thank you, sir. Thank you.
Thank you, Dr. Shoeb.
Yes.